Am I audible?
Yes, sir.
Yeah. We'll start in 2 minutes. Good afternoon.
Hi, sir.
Hi, good afternoon. मला CV स्लाइड लागेल टेक टीम आहे. Yeah, good afternoon, all of you. For today afternoon's very important industry session sponsored by Pfizer. And as we all are aware of increasing carbapenem resistance, today we are very privileged to have with us Dr. Parikshit Prayak sir, who is consultant transplant infectious disease, Dinanath Mangeshkar Hospital. He is a member of Infectious Disease Society of America, European Society of Infectious Diseases, and Infectious Association of USA. He's only trained in transplant ID consultant in this part of the world, and we are really privileged to have this eminent faculty for today's topic, the threat of CRE, detection, diagnosis, and decisions. So, we'll requesting Parikshit to please enlighten us on this very important topic.
Thank you so much, sir, and good afternoon, everyone. Let me just share my screen. Is my screen visible?
Yes, sir.
Okay. Yes. So good afternoon, everyone, and thank you so much for inviting me to this wonderful platform. So as Borauke sir mentioned, in the next 50 to 55 minutes, we are going to be talking about carbapenem-resistant gram-negative organisms. And we all know, what a menace they are in our ICUs. So I'll be spending less of time on the epidemiology and more time, trying to discuss the important practical details as to how to detect them, how to diagnose them, and more importantly, or most importantly, how to make clinical decisions, based on this type of knowledge. So again, thank you very much, Pfizer, for inviting me for this wonderful session. And thank you to the Best of Brussels Organizing Committee. So as we all know, carbapenem resistance is a real threat in the Indian ICUs. Now, if you look at WHO projections, and these were projections even before COVID, so, some of these things look even worse at this point of time. So the projections are that in 2030, 100% of the Klebsiella in the country will be carbapenem resistant. And this is a very scary situation, which means that, if we are talking in BOB 2030, we would not be talking about carbapenem susceptible bugs at all. And I think that is a very scary situation. So I think this slide alone is enough for us to know what kind of threat this is. So I'm not going to be talking a lot about epidemiology, because gram-negative resistance itself, it should be a 4 or 5 day course. So, to cover it in an hour, I think we will do away with the epidemiology. Let us try to understand the basics of gram-negative resistance. So when I have a gram-negative bacteria, what does it do to produce this type of resistance? Now I have this beta-lactam antibiotic here. When I say beta-lactam antibiotics, what it means is penicillins, cephalosporins, the Monobactam aztreonam, and the carbapenems. So all beta-lactam antibiotics, they enter through this porin channel, which is shown in purple. And once they enter, then they bind to the penicillin binding proteins and they exert their mechanism of action, which is to sort of prevent the stability of or disrupt the stability of the cell wall. Now, during this process, resistance can develop along various steps. So one step would be that the bacteria don't allow the beta-lactam antibiotics to enter at all. So these are known as modified pore-in channels. So you see the channel here in red. It will not allow my beta-lactam antibiotic. Again, what's a beta-lactam antibiotic? Penicillins, cephalosporins, aztreonam, and carbapenem. These are the 4 classes of beta-lactam antibiotics. So it will not allow these antibiotics to enter at all. And these are known as modified pore-in channels. The next mechanism could be that the antibiotics are able to enter, but immediately they are kicked out in the opposite direction. They are kicked out of the bacteria by pumps which act in the opposite direction to pore-in channels. So pore-in channels allowed my antibiotics to enter. Efflux pumps are going to push my antibiotics out of the bacterial cell. The third and the most complex mechanism of resistance is production of enzymes known as beta-lactamases, what is shown in green in this figure. So what are beta-lactamases? Just as we have beta-lactam antibiotics, the enzymes that are going to degrade them or hydrolyze them are going to be known as beta-lactamases. And fourth and last, but definitely not the least, we have modification of penicillin binding proteins. So the ultimate site itself, or the ultimate target, or the ultimate site of action itself is altered. And this is colloquially known as PBP mutations or alterations. And this is an important step which is emerging in gram-negative resistance. So when we look at beta-lactamases, let's try to spend about 15 or 20 minutes in trying to first understand what are beta-lactamases and how do we detect beta-lactamases in clinical practice and what strategies we have to combat these beta-lactamases. And then I will be going over to a few illustrative cases and trying to highlight one point in every case. So when we look at beta-lactamases, as I mentioned, these are enzymes which destroy or hydrolyze beta-lactams. Now I have already mentioned what are the beta-lactams. So you have penicillins, you have cephalosporins, you have the monobactam aztreonam, and you have carbapenems. So enzymes which destroy only the penicillins, these would be known as penicillinases. If my enzymes are able to destroy up to the 3rd generation of cephalosporins, which means that they are able to destroy up to ceftazidime and ceftriaxone, but they'll spare my 4th generation cephalosporin, which is cefepime, these enzymes would be known as AMP-C enzymes, and these are usually inducible. What do you mean by inducible? What I mean is that once the bacteria is exposed to a beta-lactam, these enzymes are expressed. So they may not be there at the beginning of therapy, but these bacteria have the ability to express them. So, down the road, 3, 4, 5, 7 days into therapy, these could be expressed. Then in red are shown the enzymes which we very commonly encounter in our clinical reports and in Indian ICUs, which are known as ESBLs or extended spectrum beta-lactamases. And then last, but definitely not the least, what we will be talking about this afternoon, which are carbapenemases. So the important carbapenemases in clinical practice, if you had to take home anything from this lecture, it would be the important carbapenemases in clinical practice, which would be KPC, NDM, which is a class B carbapenemase, and the oxas. So I'm going to be going through some of these enzymes in much greater detail. So as I mentioned, this is one way of classifying. The other way of classifying these enzymes is what is popularly or commonly known as the Ambler's classification. So this is used a lot in clinical practice. It's used by most laboratories also for reporting. So the Ambler's classification basically divides these beta-lactamases into 4 classes. So class A, B, C, and D. So I'm going to be talking a little bit in detail about each class. So if you look at class A again, it will have a number of different enzymes. We'll go through that. Class B will be our metallobeta-lactamases. Class C will only have AMP-Cs. So I'm not going to be talking a lot about class C because class C contains only AMP-Cs. Again, to revise, what are AMP-Cs? Enzymes which destroy only up to the 3rd generation of cephalosporins. And then we have class D, which is a very heterogeneous, complex family, which is known as the OXA family. Now, why are these enzymes having such heterogeneous names? The reason is that there is no pattern for this nomenclature. For example, OXA is named OXA because it hydrolyzes oxacillin more than penicillin. Or TEM is named TEM because it was found in a patient called Temonera. So just to give you an example, there is no one system of nomenclature here. These enzymes derive their names from various different properties. So let us see each of these classes. As I mentioned, class A, B, C, and D. So we'll look at definitely class A, B, and D. Why aren't we looking at class C this afternoon? That's because class C contains AMP-C enzymes, which destroy only up to the third generation of cephalosporins. So I'm going to be sticking to carbapenemases, or enzymes which destroy carbapenems, for which we have very limited clinical options. So let us look at class A. Now, what does class A contain? As I mentioned, class A is a diverse class. It's a large class of enzymes which contains both ESBLs as well as carbapenemases. Now, which are the class A ESBLs? The commonest ones that we see in clinical practice are the ones that I have put in red here. But even out of that, if I had to paint one dark red, it would be CTXM. So CTXM is the enzyme. If you had to remember one ESBL in practice in India, it would be CTXM. So CTXM is our enzyme which is very commonly prevalent in our Enterobacteriaceae. When I mean Enterobacteriaceae, I usually mean the lactose fermenters. So Klebsiella, E. coli, Enterobacter, Citrobacter, Serratia, and so on. So basically, our common organisms that we see in the ICU, except bacteria like Acinetobacter or Pseudomonas. Acinetobacter, Pseudomonas, these are non-Enterobacteriaceae. So when I talk about Enterobacteriaceae, and when I talk about ESBLs, the commonest ESBLs the commonest ESBL that we see in India is CTXM. Now, there are various classes of CTXMs. Again, I'm not going to be going into the details of ESBLs, because what are those? Those are enzymes which destroy all cephalosporins, but spare usually all your carbapenems. So these are ESBLs. So CTXM would be important. Then some of the other enzymes, like TEM and SHV, we do see them in clinical practice. I'll be showing you some examples. And PAIR and Web or VB, these are usually ESBLs of Acinetobacter and Pseudomonas, unlike CTXM, which is usually an ESBL of Klebsiella and E. coli, or the Enterobacteriaceae. So going over to the class A carbapenemases, the one which is very distinct in this class is KPC. So let's talk a little bit about the class A carbapenemases, which is the KPC. So KPC is not endemic in the Indian subcontinent. What do I mean by that? Usually, KPC is endemic in the Western world. So if you look at the KPC map, then the endemic countries would be North America, parts of Europe, parts of South America. Whereas if you look at India, KPC is not endemic. Now, we have been doing a study in our hospital at Dinanath Mangeshkar Hospital, for the last 2 years, wherein we have included more than 200 isolates of carbapenem-resistant bacteremias. And so far, we have had only 1 or 2 cases that I can remember. I mean, we are in the process of compiling the data and writing it up, but only 1 or 2 cases that I can remember which have produced KPC amongst the 200 isolates of carbapenem-resistant bacteremia. So only bloodstream isolates and only carbapenem-resistant isolates, because we run a 20 enzyme PCR panel on each of these isolates. So KPC is not a very common enzyme in the Indian subcontinent. So then there are again various variants of KPC. So KPC1 and KPC2, these are the most problematic. Why are they problematic? Because they have recently shown tendency to mutate and become resistant to some of the beta-lactamase inhibitors that we use in clinical practice. So if we had to simply remember, KPC is an important enzyme of Klebsiella E. coli, sometimes can also be produced by Pseudomonas, but it's usually not endemic in the Indian subcontinent. So we see only sporadic cases of KPCs. Now, when you look at each class of enzymes, we have to also know our BLI spectrum, which I'll be giving you at the end of each class of enzymes, because this is very practically useful. So, when we look at class A enzymes, let us look at the important class A enzymes. So CTXM, as I mentioned, important class A enzyme. It's an ESBL produced by Klebsiella and E. coli. Is it inhibited by Tazobactam? It can be, or it should be inhibited by Tazobactam, but it's uncertain. And that's why you will see some of your ESBL reports being susceptible to piperacillin Tazobactam, whereas some of your ESBL reports will be resistant to piperacillin Tazobactam. So just the presence of a CTXM doesn't really tell me whether my isolate is going to be susceptible or resistant to piperacillin Tazobactam. And that's why I always need to confirm susceptibility. Now, that's another debate. If you find piperacillin Tazobactam susceptible, can you use it for an ESBL infection? Again, that's a debate in itself. For certain situations, you can. For certain situations, it is best avoided. Whereas if you look at avibactam, which is in the form of ceftazidime avibactam or Zavicefta, the new molecule, then avibactam does inhibit CTXM. If you look at the two other ESBLs of Enterobacteriaceae in class A enzymes, SHVs and TEMs, those are usually weaker enzymes. So both Tazobactam and Avibactam should be able to inhibit. So really, what is the difference between Tazobactam and Avibactam when it comes to class A enzymes? So when you look at the KPCs, that is where you find your biggest difference. So if you look at KPCs, Tazobactam will not be able to destroy a KPC, whereas Avibactam will be able to destroy a KPC. So if I have a Klebsiella, which is producing KPC carbapenemase, which means that it is resistant to my meropenem, imipenem, ertapenem, and so on, then using only ceftazidime avibactam can be a good way to combat this type of an infection, because avibactam will destroy your KPCs. If you look at Pseudomonas, that is where the problem is. So if you look at Pseudomonas and Acinetobacter, as I mentioned, they do produce some other ESBLs like PER and WEBs. Now, WEB is a problematic enzyme, and we have encountered WEB in our settings. We have encountered PER as well. WEB is an enzyme which is not inhibited by avibactam. So Pseudomonas and Acinetobacter becomes a little bit trickier in this type of situation. So these were our class A enzymes. Now let us go to the class B enzymes. As I mentioned, class B enzymes are really the bane of the Indian subcontinent. So when you talk about class B enzymes, these are metallo-beta-lactamases. So these are, a little different when it comes to enzymatic structure. These are metallo-beta-lactamases, and which is the commonest one that we see in practice. It is the New Delhi metallo-beta-lactamase, named so because it was discovered from a Swedish patient who was visiting our capital back in 2009, and he happened to harbor an Enterobacteriaceae which was producing the NDM, or the New Delhi metallo-beta-lactamase. Now there are various metallo-beta-lactamases, WIM and IMP, the Verona integrase as well as the imipenemase producers. So they all are seen in this class. But commonly what we see in the Indian subcontinent is NDM. Of course, we also do see a lot of WIM and IMP, especially in the Pseudomonas. So again, if you had to remember three important class B enzymes, these are carbapenemases, and these are NDM, or the New Delhi metallo-beta-lactamase, and WIM and IMP. So these would be the three important enzymes. Now let us talk a little bit in depth about NDM. So what is NDM? It is the New Delhi metallo-beta-lactamase. There are various variants of NDM which have been described so far, but look at this important figure here. So if you look at the various variants, they differ a little bit as far as their ability to hydrolyze beta-lactams. But what is the common theme? The common theme is that it is a problematic enzyme. And why is that? The reason is that it is able to destroy all our beta-lactam antibiotics. So all my beta-lactam antibiotics are uniformly destroyed by NDM producers. So there is no discrimination when it comes to killing my antibiotic. They will destroy all my cephalosporins. They will destroy none of the beta-lactamase inhibitors will be able to destroy an NDM. So it is problematic except Aztreonam. Except Aztreonam, an NDM enzyme is able to destroy all my beta-lactam antibiotics. So look at the beta-lactam antibiotics here, the penicillins, the cephalosporins, the carbapenems, again, piperacillin, tazobactam, they all have very high MICs when an isolate is producing an NDM enzyme. As I mentioned, there are some variants. So for example, if you look at NDM5 or if you look at NDM20, they might be actually a little bit more potent than the parent NDM1 when it comes to carbapenem hydrolysis. But very strikingly, they will spare Aztreonam. So Aztreonam, look at the MICs, 0.03, 0.03, and 0.06. So very important take-home point, Aztreonam is spared when by an NDM producer. Now look at colistin and tigecycline or gentamicin in this figure here. Now these antibiotics are not, they have nothing to do with NDMs, right? Because NDMs are going to destroy only my beta-lactam antibiotics. So tigecycline, colistin are not beta-lactam antibiotics. But epidemiologically, I think the most important word here is epidemiologically, colistin and tigecycline usually retain susceptibility against NDM producers. So if I take 100 NDM producers, usually I'll find that, in about 80 to 90 cases, colistin, and maybe in 70 to 80 cases, tigecycline would have retained its susceptibility. That doesn't happen for aminoglycosides and fluoroquinolones. Usually NDM resistance is also epidemiologically accompanied by cephalosporin, by fluoroquinolone and aminoglycoside resistance. So usually in India, when I have an NDM producer, it is resistant to all beta-lactams except Aztreonam. it is resistant usually to aminoglycosides, and it is resistant usually to fluoroquinolones. And that's why colistin, tigecycline, minocycline, these are my only options left when it comes to an NDM producer. Now you will ask me that in clinical practice, we very rarely see, aztreonam susceptibility even in the presence of NDM production. The reason is that aztreonam is destroyed by many other enzymes. So unfortunately, what happens in India is that these bugs are not single enzyme producers. So multiple enzymes are produced, which some of them may destroy aztreonam. But if you have a pure NDM producer, aztreonam should usually retain its susceptibility. Now look at the NDM map. You make the blue areas red and you make the red areas blue from the KPC map, and you have the NDM map. So what does it show? India is the home of NDM producers. These bugs are endemic in the Indian subcontinent. So this is where NDM producers originated. This is where they live, like you and me. So this is where, we have endemic spread of the NDM producers. Whereas if you look at the Western world, there are only sporadic cases of NDM producers. So usually visitors to the Indian subcontinent will carry the NDM back to their home countries in the Western world. Now, what happens to my beta-lactamase inhibitors? So not surprisingly, but very disappointingly enough, all my beta-lactamase inhibitors are redundant when it comes to an NDM producer. Why? Because none of these BLIs, tazobactam, avibactam, the newer BLIs like relebactam and vaborbactam, which have been in use in the Western world. You have, imipenem and meropenem, which have been combined with relebactam and vaborbactam. So none of these beta-lactamase inhibitors are able to destroy NDM enzyme. So again, very important. Now we are in the process of, phase 3 trials of cefepime and zidibactam. So zidibactam is something which offers us hope. So zidibactam, nacobactam, these are the newer BLIs in the pipeline. So that does offer us hope. But right now in the clinical repertoire that we have here or anywhere in the world, there is no single beta-lactamase inhibitor which is able to destroy the New Delhi metallo-beta-lactamase. So again, very important information. So with that, let's go over to the OXA enzyme. So as I mentioned, the OXA family is a very heterogeneous family. It contains numerous different enzymes. Now, if I had to remember a few from this, one would definitely be OXA48. So this OXA48 family or the OXA48-like enzymes are the carbapenemases of E. coli, Klebsiella, or the Enterobacteriaceae. So remember, once we have Enterobacteriaceae which are producing OXA48, usually they are carbapenem resistant. Whereas if you go to this chart again, then which are my carbapenemases of Acinetobacter? These are usually OXA23, OXA24, OXA51, OXA58. Now, OXA51 again is a unique enzyme. So far in the 2 years that we have been doing our gram-negative project, we have rarely ever encountered an OXA51 which is carbapenem resistant. The reason is that it requires another promoter region for it to produce carbapenem resistance. So usually what we are seeing is that at least in our setting, OXA51 is not producing carbapenem resistance. But again, what are the important Acinetobacter oxas? OXA23, 24, 51 and 58. Whereas OXA48, these are the carbapenemases of E. coli and Klebsiella. Now, again, for the lack of time, I will not be going over some of these individual enzymes, but we are shortly, coming up with a sort of 7 or 8 session gram-negative course actually with Pfizer, and that will be our opportunity to discuss many of these enzymes in tremendous depth. So, when you look at the OXA family, let us talk about the OXA family. So, as I mentioned, if we have to remember 3 important categories of OXAs, as I would put it. We have to know what is OXA48, because OXA48 is a very commonly encountered enzyme in India. It is the carbapenemase of Klebsiella E. coli or Enterobacteriaceae. So Enterobacter, Citrobacter, Serratia, Klebsiella E. coli. Now, is it inhibited by tazobactam? No. Is it inhibited by avibactam? Yes. So that is again another place where ceftazidime avibactam would score over piperacillin tazobactam. Now, Acinetobacter oxas are usually not inhibited by either avibactam or tazobactam, and so are the Pseudomonas oxas. So that's why increasingly as you go through my talk, you will realize that for Acinetobacter, ceftazidime avibactam plus or minus aztreonam is a poor choice. For Pseudomonas, there is a lot to Pseudomonas resistance even beyond enzymes, and some of the Pseudomonas enzymes cannot be destroyed by avibactam. So we have to take it with a pinch of salt. We have to be cautious when we are using something like ceftazidime avibactam plus aztreonam for Pseudomonas. Whereas for Enterobacteriaceae, usually it is a robust choice. So for Klebsiella, E. coli, Enterobacter, Citrobacter, and so on, it is a robust choice. Now, with this introduction, let us actually go over to, how do we detect and diagnose these enzymes? So it's all fine to say, that I have an OXA51 producer or an OXA58 does this or an OXA48 does this. But how do we actually gain access to this type of information in clinical practice? Because if you are not able to detect enzymes, then all this becomes redundant. Whatever that bug is producing, if we don't know what it is producing, then all this information is meaningless. So now we are in this stage wherein we are able to, in clinical practice, detect these enzymes. And these are some of the ways in which we can detect this. Of course, there are more sophisticated ways like sequencing the enzymes, but these are the simple clinical commercial tests which are used world over to detect these enzymes. So we have the Carba-R test. Many of you must have used this. Last we surveyed this, about 100 hospitals in the country were using the Carba-R test. Then we have eSIM and MSIM tests. We have the sepsis flow panel, which is a PCR panel, what we are using in-house in our setup in Dinanath Mangeshkar Hospital. And I'll show you, how the reports are generated. Then we have BioFire panels. So many of you must have used the BioFire meningitis or encephalitis or respiratory panel in the COVID pandemic. So similarly, they have a blood panel, which shows us some enzymes. And then for those labs which use the BD systems, there is a BD CPO panel as well. So let us go through some of these tests and see how it can help us in clinical practice. Now let us look at the expert Carba-R. So usually labs which do the gene expert for TB should be able to do an expert Carba-R test. It's a simple test, but it's a robust test. Why? Because it tells me the main carbapenemases in clinical practice in India. It tells me whether a KPC is produced, an OXA48 is produced, and whether class B enzymes are produced. So as I mentioned, NDM, women, IMP, important metallobeta-lactamases, KPC, important class A carbapenemase, and OXA48, important class D carbapenemase of Klebsiella and E. coli. So it tells me whether these 5 important enzymes are produced or not. Now, how does this help me clinically? Let's say I have a patient who has Klebsiella bacteremia, and this Klebsiella is resistant to all carbapenems. So I quickly run a Carba-R test. In the next 3 or 4 hours, my laboratory should be able to tell me what kind of enzymes it is producing. So if my microbiologist calls me up and says that it is producing KPC plus NDM, what should I use? So if I use the ceftazidime avibactam will destroy the KPC, but NDM will be a problem. So what must I add? I must add aztreonam, which is not destroyed by NDM. So in clinical practice, the simple decision that it allows me to take is, should I add aztreonam or not, especially for my Enterobacteriaceae. So for my E. coli, Klebsiella, Enterobacter, should I add aztreonam to ceftazidime avibactam? This is the kind of good, quick answer that it provides. This is the question to which it provides this answer. Now, eSIM and MSIM tests, again, I will not go into the microbiological details, but, these are good, simple tests. They tell me 2 things. A, is a carbapenemase present? And B, whether it's a serine carbapenemase or a zinc carbapenemase, which means that it answers 2 questions. Is a carbapenemase present? Yes or no. And is a metallobeta-lactamase present? Yes or no. Now, this is the in-house PCR test that we are using, which is European validated. Now, it has been, my experience with this has been great. In the last 2 years, as I mentioned, we have run this test on more than 200 patients in the hospital. The good thing about this is that it is a PCR test. So as soon as growth is detected, we are able to run this test. So about 48 hours before you have the actual susceptibility results, even about 48 hours before you can run a expert Carba-R, we are able to run this PCR panel. Now it gives us information about a lot of enzymes and bugs. So this is the kind of utility it has. So this is a patient with neutropenic fever. The lab calls you and tells you that the blood culture is growing a gram-negative bug. So you run this PCR panel, and 4 hours later, the microbiology lab calls you and tells you that it is a Klebsiella, and look at the kind of enzymes it is producing: SHV, CTXM, NDM, and OXA48. So let us try and dissect out this report. So what is SHV? SHV can be an ESBL, which is class A. CTXM is almost always an ESBL. which is again class A. NDM is almost always a carbapenemase, which is class B. And OXA48, barring some variants of OXA48, is usually a carbapenemase, which is class D. So now let us see, what will happen if I use something like piperacillin tazobactam. Will it work? No, because SHV it may be able to destroy or should be able to destroy. CTXM it may be able to destroy, but NDM and OXA48 it will not destroy. Let's see what happens if I use something like aztreonam only. So NDM, will it destroy aztreonam? No, but the SHV, CTXM, and some variants of OXA48, they all destroy aztreonam. So again, aztreonam will not work. Will a carbapenem work? Something like meropenem? No, because NDM and OXA48 both will destroy meropenem. So let us see what will happen if I use ceftazidime avibactam alone. So avibactam will destroy SHV, CTXM, and OXA48. But what will remain? NDM. As I mentioned, BLIs in clinical practice right now are not able to destroy NDM. So what will happen when I use ceftazidime avibactam alone? It will not work because there is an NDM producer there. So that leads me to a very innovative way of dealing with these bugs, which is combining ceftazidime avibactam plus aztreonam. So what will happen is that avibactam will destroy SHV, CTXM, and OXA48, and NDM will remain, but only NDM will remain, and that only NDM which remains will not be able to destroy my aztreonam, and aztreonam will finally destroy the Klebsiella. It's like a game of chess. Ultimately, you have to reach the bug. We are not just interested in destroying the enzymes. At the end of the day, we are interested in destroying the bacteria. So that aztreonam will destroy Klebsiella. So when I combine ceftazidime avibactam with aztreonam, ultimately at the end of the day, I will at least optimize my chances of clinical success. Of course, there is more to this, in terms of PKPD, in terms of certain variations of the enzymes and so on. But whenever you have this, we usually try to run synergy testing. Since we don't have aztreonam avibactam in clinical practice right now, we are running synergy tests for all these isolates. And I'll tell you what that is, via some cases. So next, the next method of detecting these enzymes is something known as the BioFire BCID panel. So the BioFire blood culture identification panel. Let us concentrate on the right hand or column, and let us look at what enzymes it is detecting for us. So it is detecting IMP. What is IMP? It's a class B carbapenemase. KPC is a class A carbapenemase. OXA48 like these are class D, usually carbapenemases. NDM class B, WIM class B. So that menu card is similar to a CARBA-R test, except it is importantly also detecting CTXM, which is useful in clinical practice. Now it is also detecting MCR1 mediated colistin resistance, but that is not a very common mechanism of resistance in the Indian subcontinent. So these are the kind of gram-negative enzymes that your BCID or BioFire panel is detecting. Again, a good robust panel has good specificity, has good sensitivity, but cost can be an issue. But it does, give you at least as much information as a CARBA-R plus the detection of CTXM as well. Now, these are some of the ways in which you can predict what type of enzymes are being produced, or what is the kind of resistance mechanism which is at play. So this is where you should call up your microbiologist or an ID physician and get help, because based on the culture reports, we can at least in most cases guess the enzymatic pattern or guess the mechanism of resistance. So this is the summary of the big four in India. So E. coli, Klebsiella, Pseudomonas, and Acinetobacter. These are usually the big four bugs that we see in our ICUs. So which enzymes do they commonly produce? E. coli in India usually produces more NDM than OXA48. So NDM again is a class B carbapenemase. OXA48 is a class D carbapenemase. What do most of our Klebsiella produce? OXA48 and then NDM. So more Klebsiellas produce OXA48 in India. What do our Pseudomonas isolates produce? Usually they produce WIM, NDM, and IMP, so class B enzymes. And what do our Acinetobacter isolates produce? As I mentioned, they usually produce OXA 23, 24, 51, 58, and class B enzymes. Now, very scarily, the colistin resistance has been described as about 30 to 40% for carbapenem resistant Klebsiella in the country. Now, you might say that, in my clinical practice, I have rarely encountered a Klebsiella which has been reported as resistant. There are a couple of issues behind this. One is the method in which we are testing colistin. So the Vitek might actually underestimate Vitek's machines, which are very commonly used in our labs. They might underestimate colistin resistance, and we'll get we'll throw some more light on this. So this has been our own experience at DMH. 40% of our carbapenem resistant Klebsiella have been colistin resistant lately. 80% of our carbapenem resistant Klebsiella have been multiple enzyme producers, just like the report I showed you. They usually produce SHV, CTXM, NDM, OXA48. So usually they do produce 2, 3, 4 enzymes. It's not just restricted to one enzyme production. And CTXM has been the commonest ESBL, no surprises. For carbapenem resistant Klebsiella, we have more OXAs than NDM. And for E. coli, it is the other way around. It's more NDMs than OXAs. So with this, in the next 20 minutes or so, let me try to go through a few illustrative cases, which will try and answer now, since we have gone through this background of enzyme production and how do we detect and diagnose this. Let us go to the important part of taking therapeutic decisions or management decisions. So this is our 40-year-old gentleman with acute myeloid leukemia who underwent induction chemotherapy and then developed febrile neutropenia. So his duration of neutropenia was 5 days. When the fever started, that was the quantitative neutropenia. But as we all know, AML patients can have qualitative neutropenias for much longer before presentation. So he was started on piperacillin tazobactam for neutropenic fever. On day 4 of his fever, he remained febrile and was changed to meropenem. Day 6, he continues to have fever, and now the lab calls you and says that the blood cultures are growing GNBs. So it is most likely looking like an Enterobacteriaceae. So the blood cultures are growing Enterobacteriaceae like GNBs. So possibilities are something like Enterobacter, E. coli, Klebsiella. So not Pseudomonas or Acinetobacter. The lab says that, they are looking like Enterobacteriaceae. So what options do we have? So this is a patient who is growing Enterobacteriaceae while being on meropenem. So what are our options? Some of you might change him to colistin. Some of you might continue the meropenem and add colistin. Some of you might change him to ceftazidime avibactam. Some of you, I don't think anyone will continue meropenem. Some of you might add certain other non-beta-lactam agents like fosfomycin, tigecycline, minocycline, and so on. Or some of you might go for ceftazidime avibactam plus aztreonam. So let us see, how do we answer this question and how do we tackle this case? So for this, again, enzymatic knowledge is very important. Broadly speaking, you have 2 approaches to this patient. Either you have a polymyxin-based approach or you have a BL-BLI-based approach. And third, rarely, you will have non-polymyxin, non-BL-BLI-based approach, something like fosfomycin or chloramphenicol, minocycline. But usually, the evidence for using them as monotherapy is sparse. So usually, they will be combined with something like polymyxin. So broadly speaking, you have 2 approaches to this patient, either a polymyxin-based therapy or a BL-BLI-based therapy. So now once we run a PCR panel on this patient, again, this is the same report that I showed you. It's showing a Klebsiella producing SHV, CTXM, NDM, and OXA48. So again, what does avibactam destroy? Avibactam will destroy our SHV, CTXM, and OXA48. And avibactam will not destroy the NDM. But what is the brighter side of this? The brighter side is that NDM is not able to destroy aztreonam. So when I combine ceftazidime avibactam with aztreonam, that is when I'll be able to get a hang on this. So he was started on ceftazidime avibactam and aztreonam. He clinically improved, right? And 48 hours after we have run the sepsis flow PCR panel, you have the complete report. Now, no surprises there. Aztreonam individually, aztreonam and Zavicefta both are resistant in this report. Now, what is the reason? I often get called, after I have started this combination, saying that, the cultures have been finalized. He is on Zavicefta and aztreonam, but they are both showing resistant in the report. Now, that is not a surprise. Why is that? Because the NDM will destroy your Zavicefta and the other enzymes, especially, CTXM will destroy aztreonam. So it is no surprise that individually both these antibiotics are resistant. It is only when you combine them that they are likely to act. But what must we do before we commit to this type of therapy? We must ensure that the combination is going to work. Now, as I mentioned, soon we'll be having aztreonam avibactam, because at this point of time, really we are using the avibactam part of Zavicefta more than the ceftazidime part in such cases. Of course, in some cases we do when we use it as monotherapy. But when we are combining it with aztreonam, we are more using avibactam and aztreonam out of the 3 drugs there. So we must always sort of confirm this with synergy testing. So this was the synergy testing, which was, and this, so this is a picture from our own lab in the Nanath Mangeshkar. So this is, when we did the synergy testing. So you can see these 3 test tubes here. One contains only ceftazidime avibactam, so or zavicefta. One contains only astrolam. So you have turbidity or growth in both those test tubes. When you combine, so when, in the test tube which has both zavicefta and astrolam, there is a clear zone, which means that together these antimicrobials are working. So again, what does avibactam inhibit? It inhibits the class A enzymes, ESBLs, KPCs, class C enzymes, and class D enzymes of Enterobacteriaceae. So it's a great drug, for E. coli, Klebsiella. Of course, we are starting to see some resistance there, which I'll come to. Let's go to our second case. So we have a patient with fever and abdominal pain. He was found to have liver abscesses. He undergoes drainage of the liver abscesses and is found to have Klebsiella in the blood culture. Now, again, resistant to astrolam, resistant to ceftazidime avibactam. So what is the likely mechanism involved? Can it be NDM only? No. If it would have been a pure NDM producer, what would we expect? We would expect astrolam susceptibility. Can it be NDM plus KPC? Yes, because KPC will make astrolam resistant and NDM will make zavicefta or ceftazidime avibactam resistant. So it can be that, just that epidemiologically in India, this combination is less likely. If this is an isolate from the US, then definitely this is likely. NDM plus OXA, definitely it is possible. So NDM plus OXA 48, this is the more likely combination of enzymes in India. So now, what are our options for this patient? Our options for this patient are, ceftazidime avibactam plus astrolam, of course, confirmed with synergy testing, or polymyxin-based therapy, as I mentioned. Now, look at this report again. Colistin has been described as intermediate. Now, let me give you an update that for the last 1.5 years, CLSI has updated their guidelines, and we are no longer using the term colistin susceptible. So all our isolates which have colistin MICs, let's say less than 2, they are termed as colistin intermediate, and more than 4 is termed as colistin resistant. So we no longer use the term colistin susceptible. The reason is the pharmacodynamic properties of colistin. So colistin as monotherapy is unlikely to achieve good pharmacodynamic targets, and that's why based on this, and I'll show you that information briefly. Based on this, CLSI has abolished the term colistin susceptible. So now when you look at this patient, you might ask me that, I have 2 options here. One is using ceftazidime avibactam plus astrolam. The other is using polymyxin or colistin-based therapy. So the question is, what is better? So is polymyxin-based therapy better, or using ceftazidime avibactam plus astrolam better for this patient? The other question that we'll try to answer is that if we do choose polymyxin, should we use it alone or should we use it as combination therapy, right? So these are the questions that we will try to answer. Before we get to that, whenever you see such an isolate, and if you are thinking of using polymyxin therapy, it is always better to talk with your microbiologist about the true polymyxin or colistin MICs. Now, the reason I say this is, as I mentioned, Vitek systems can underestimate colistin resistance. So which means that if it gives you colistin MICs of less than 2, they might actually be more. So they might underestimate colistin MICs. So the true MIC might actually be higher. So that's why, again, these are a couple of studies which throw light on this. For the lack of time, I won't go through them in detail. And colistin is a difficult antimicrobial to test. So there are several issues with testing for colistin MICs. So the best way of doing this is broth microdilution. But broth microdilution for colistin is challenging because of the lack of commercial panels, a lot of properties related to polymyxin itself. It binds to the surfaces, so it sticks to the wells of the broth microdilution test and so on. So true colistin MICs are challenging in clinical practice. One way of doing it is the colistin broth disc elution test, which we are doing in-house in the Nanath Mangeshkar Hospital. So look what happens when I run this test for this patient. They had told me that the MIC was less than 2 on Vitek, but when I actually ran this drug elution test, they told me that the actual MIC is more than 4, which is actually resistant. So again, we have had many cases like this in the last 3 to 6 months since we started actually doing colistin MICs by the elution test. So again, very important to talk to your microbiologist. So whenever you are planning to use polymyxin, colistin, always talk to your microbiologist. What are we using for colistin testing? How can we make it better? Can I assume that, the Vitek MICs are right? Or are we using Vitek or are we using something else? So always talk to your microbiologist, ask him, how did you do colistin resistance testing, or how did you find out for the colistin MICs? So again, this patient, when we did the drug elution test, it was actually more than 4. So which really dampens my enthusiasm for colistin. But let's say it would have been less than 2. Then can I still use colistin based therapy, or should I go for ceftazidime avibactam plus aztreonam? So let's say, for financial reasons or lack of availability, I do decide to use polymyxin based therapy. Should I use monotherapy or should I use combination therapy? Again, this is a burning question. It forms, the topic of debates of many ID discussions all over the world. So again, it's not possible to answer this in 2 or 3 minutes. We need an hour or so just to answer this question. But broadly speaking, the evidence for using combination therapy is stronger for Enterobacteriaceae and decent for Pseudomonas and not very strong for Acinetobacter. Which means that if I have a polymyxin, if I decide to go for a polymyxin-based therapy and I have a Klebsiella bacteremia, I will, in my clinical practice, I will usually use combination therapy. If it's E. coli, I will usually use combination therapy. If it is Pseudomonas, also I personally will use combination therapy. If it is Acinetobacter, the evidence is not so strong. Now, when they were making the polymyxin guidelines, when this question was posed to a committee of 25 international experts, the answer was split as 13-12. So people who voted for combination versus people who voted against combination therapy, the opinion was divided as 13-12. So again, it's a dicey prospect at this point of time. I personally do use combination therapy, but it is non-carbapenem based combination therapy most of the times in India. So these are again the same studies. So now let's say you do decide to use combination therapy. Now this is a Klebsiella. You have decided to use polymyxin based therapy, and you have also decided to use combination therapy because it's Klebsiella. Now, what is the drug that you will combine with polymyxin? I think this is very important because inadvertently, what happens in most ICUs, across the board is that polymyxin gets combined with meropenem. So, usually we are reluctant in stopping meropenem, and usually when it is combination therapy, our go-to option or the go-to choice is polymyxin plus meropenem. Now, really, we should always try and answer this question, which is the drug that I should combine with polymyxin? So the obvious answer every time is not meropenem. In fact, if you look at studies, the moment meropenem MICs go beyond 16 or definitely above 32, polymyxin plus meropenem offers very little synergy benefit. So it is almost as good as giving the patient only polymyxin. So when the MICs are more than 16, we should usually not add polymyxin or meropenem to polymyxin. We should combine polymyxin with something else. And what is that something else that we use? Usually what we try and do is we find out what is known as the efficacy index. So what we do is divide the MIC by the breakpoint. Now this breakpoint and the MIC, both these pieces of information are readily available with your microbiologist. So every time you have a gram-negative isolate, the first place to go and get all this and discuss all this is your microbiologist. So once you have the MICs and the breakpoint, let us compare the three drugs here. So let us compare, tigecycline, fosfomycin, and meropenem. So if you divide 4 by 2, the answer is 2. So efficacy index of tigecycline for this patient is 2. For meropenem, it is 32, 64 divided by 2. And for fosfomycin, it is 1, 32 divided by 32. So it is 2, 32, and 1. So the lowest number out of this is 1. And that's why actually for this patient, fosfomycin efficacy index is actually the most favorable. So if I had to pick a combination therapy for this particular patient, if I was not going to use ceftazidime avibactam plus aztreonam, I will use polymyxin plus fosfomycin for this particular patient. Now, what about using amikacin monotherapy? Amikacin monotherapy can be a decent option, but however, in our clinical practice, usually we don't have access to amikacin levels. So usually amikacin levels are difficult to get in clinical practice because usually, ideally, it should be guided by levels. And why is that? because peak levels correlate to efficacy. Usually what you should try and achieve is at least 10 times the MIC as far as peak is concerned. So if I have an MIC of 1, I should achieve a peak level of 10. But now here the MIC is 8, which means that a good peak level will be 80. Can I achieve this humongous level? I cannot achieve it without compromising safety or toxicity. Because what happens is when peak levels rise, so do the trough levels. And that's why I'm going to either run into the zone of nephrotoxicity or not going to be able to achieve a good peak level. So that is why, so this is the art and science that goes behind choosing the combination therapy. Also, you have to consider, where are you targeting your antibiotics? So what is the site in the body? So whether I want genitourinary penetration, whether I want CNS penetration, whether I need good levels in the bloodstream, which tigecycline won't give me. These are various decisions that go into choosing a combination therapy. So don't always go to polymyxin plus meropenem. And then last but not the least, let us try to answer, what is better? So is polymyxin plus fosfomycin better for this patient, or ceftazidime avibactam plus aztreonam better for this patient? Now, we are in the process of getting this evidence, or trying to answer this question. So far, the studies that have looked at alternative regimens, so polymyxin regimen versus an alternative regimen when it is available or when it is a good option, so far the evidence is tilting slightly in favor of non-polymyxin based therapy. So we are moving more and more away from polymyxin based therapies. And why is that? The reason is that, as I mentioned, we have abolished the term polymyxin susceptible. So we are no longer calling it as polymyxin susceptible. We are either calling it as intermediate or resistant. The reason is that it is difficult for me to achieve PKPD targets for polymyxin. Now, one of the properties here is that why am I not able to achieve this? So again, very little time for us to go through polymyxin pharmacodynamics. But simply, we have to remember that for most patients, we are unable to achieve a good AUC-MIC ratio for our polymyxins here in India. Now, when it comes to choosing polymyxin versus colistin, what do I choose? Polymyxin B has lesser nephrotoxicity, does not need dose adjustment for impaired renal function, and achieves therapeutic levels faster, but does not penetrate into the GU tract. So simply put, for all non-UTI infections, we have to choose polymyxin. For UTI, we have to choose colistin over polymyxin. Now, let us go in the last 10 minutes or so. I think it's 2 o'clock. So in the last 8 to 9 minutes, let us try to go through a couple of cases quickly. So this is a post-haplo transplant patient with AML. He is day 9 pre-engraftment, so he's still neutropenic. His blood cultures grow Pseudomonas, which is now, according to newer nomenclature, intermediate to colistin, but is resistant to carbapenems and aztreonam. And he is producing an NDM and OXA50. So the question here is for Pseudomonas, will you go for Zivasefta-based therapy? So the answer is, for treating NDM producing Pseudomonas, ceftazidime avibactam plus aztreonam may or may not work. The reason is that Pseudomonas has many non-enzymatic mechanisms of resistance. So you have efflux pumps, you have porin channel mutations. So that might lead to failure of ceftazidime avibactam. And again, even if the enzyme panel is showing only NDM, will aztreonam work? Unlikely, because Pseudomonas is an AMP-C producer, and none of the commercial tests that we have right now are able to detect an AMP-C. So that AMP-C will destroy your aztreonam. And so, as I mentioned, there are several problems with Pseudomonas. So usually, if you are using ceftazidime avibactam plus aztreonam for a Pseudomonas, you have to always confirm that the combination is going to be susceptible. Otherwise, it's safer to go for polymyxin-based therapy. But again, every time you are going for a polymyxin-based therapy, ask yourself, what is the actual MIC? Talk to your microbiology department. What is the actual MIC? Also, talk to your pharmacist, what should be a good dose for this? Because ideally, for something like Pseudomonas, we need AUC-MIC's ratio of more than 20 or 25, even higher in the pulmonary tract. So for respiratory infections, we even need a higher ratio of AUC to MIC. And roughly, a colistin level of 2 correlates with around with an AUC of around 50. So again, always ask yourself, what is the MIC? What is the AUC that I am likely to achieve? And, am I achieving a good AUC-MIC ratio? So polymyxin pharmacodynamics has to be optimized before you are using polymyxin. So some of this, is a little difficult. So some of this is guesswork, unfortunately, in clinical practice. Now, next case, Klebsiella in blood cultures. It's a pure KPC producer. So what is another very innovative way of tackling this? So now that we have ceftazidime avibactam, you will not need this because, avibactam will be able to destroy your KPC. But one very interesting way of tackling this problem is ertapenem plus meropenem. So what happens here is that KPC has a special affinity for ertapenem. So in the battle that goes on, KPC is engrossed in destroying ertapenem, and that's why meropenem secretly can go about its own work and destroy the Klebsiella. Of course, easier said than done, but this is what has been tried in a few case reports, especially coming from Europe. Now, last but not the least, let us turn our attention to Acinetobacter, next 4 or 5 minutes. So I have a patient with neutropenic fever. Blood culture grows Acinetobacter, which is resistant to carbapenems. What are the options? What are the likely enzymes? And does avibactam inhibit these enzymes? So let me tell you at the outset that ceftazidime avibactam plus aztreonam is a poor choice for Acinetobacter. The reason is that avibactam does not destroy many of the clinically important Acinetobacter enzymes. So, we talked about PER and Web. We talked about OXA23, OXA24. We talked about OXA58. We talked about the NDMs. We talked about women, IMP. So none of these enzymes are destroyed effectively by avibactam. Also, aztreonam itself is a poor anti-Acinetobacter drug. So that's why usually, I will not use this combination for an Acinetobacter isolate. So which means that usually what are my options? The base or the backbone is usually a polymyxin, and then combination therapy depending on the MICs could be something like minocycline or tigecycline, or one good way of tackling this would be something like triple combination, polymyxin plus meropenem plus sulbactam. So again, these are the studies behind that. I'm going to rush through a little bit because I have only 5 minutes left now. So again, look at this study. High dose sulbactam in combination with meropenem and polymyxin resulted in rapid eradication of the carbapenem resistant Acinetobacter baumannii. So again, always remember that these are some of the sort of innovative options that you can use. So you can tell your microbiology lab to test for ampicillin and then test for ampicillin sulbactam. This will tell you, if sulbactam itself is having any effect on this Acinetobacter. So when it comes to Acinetobacter and when it comes to combination therapy, always think of minocycline, tigecycline, sulbactam, triple combination of poly, sulbactam, meropenem, sometimes even rifampicin thrown in the picture. With minocycline, again, not much time to go through this, but whenever I am using minocycline, the first thing that I need to do is ask the MICs, because that is how I'm going to dose it. There are some patients for whom we need higher minocycline doses, something like 200 milligrams BD. It's not always one size fits all. Now, this is the most horrendous patient, or one of them that I have come across in my clinical practice. He had a pan-drug resistant Acinetobacter post-neurosurgical meningitis. Now, this is a nightmare because all the drugs here are resistant. And normally, if this would have been in the bloodstream, you would have used polymyxin-based therapy. But our backbone here is going to be broken because polymyxin is not going to have much CNS penetration. So this was a patient for whom we required IV polymyxin plus intrathecal colistin plus meropenem plus sulbactam. So that was the kind of therapy that we used, or even throwing in minocycline in there. So now sometimes what happens is like this patient here. So patient with neutropenic fever, blood cultures have shown a GNB. He was started on ceftazidime avibactam plus aztreonam, and the sepsis flow or the PCR panel showed Klebsiella with NDM, OXA48, CTXM. So this is a good combination. Avibactam will usually destroy OXA48 and CTXM. NDM will remain, but aztreonam will not be destroyed by NDM, and aztreonam will destroy the Klebsiella. So we started him on ceftazidime avibactam plus aztreonam. Day 4 of combination therapy, he actually becomes febrile again, and he's still neutropenic. So a patient who is growing a GNB on ceftazidime avibactam plus aztreonam, what will you think of? One of the most important bugs I'll think of is Acinetobacter, because as I mentioned, it's a poor combination. Sometimes Pseudomonas can also break through on this combination. Remember, I told you about efflux pumps, sporin mutations. So these can make the Pseudomonas resistant to this combination. So, and then again, you could have certain other atypicals like Elizabeth Kingia or, Chrysobacterium, Burkholderia. Some of these atypicals can also break through on this combination. So in summary, we only have a couple of minutes. So we will take questions, if Buraoke sir thinks we have time. But in summary, always think of which bug, which site, and which is the resistance mechanism involved. So always think of this, which bug, which site, and which is the resistance mechanism involved. Attempt to get maximum information from the micro lab. MICs, additional antibiotics. If you don't ask them for fosfomycin, chloramphenicol, minocycline, sulbactam, they won't tell you. Additional antibiotics and enzymes involved. Know the BLI spectrum. What is avibactam a good choice against? What is avibactam a poor choice against? Remember, approach to Enterobacteriaceae is different. So my approach to a patient with E. coli or Klebsiella is very different from my approach to a patient with Pseudomonas, which is also very different from my approach to something like Acinetobacter or atypicals like Burkholderia, Stenotrophomonas, Elizabeth kingia, and so on. Know the right dosing strategies and combinations, and last but certainly not the least, get help from your microbiology department. As I mentioned, we are in the process of formulating a 6-session course with Pfizer, wherein we would have 6 sessions of 90 minutes each, wherein we would be covering these enzymes in much greater detail, and then actually having 2 days in-house in Dinanath, to look at how this enzymatic testing is done, how we are doing synergy testing, and so on. So thank you very much for having me here. It's indeed my pleasure and a great honor to be sharing this Best of Brussels platform. And once again, thank you to Pfizer and the BOB-2021 team. So back to Borauke sir.
Thank you very much, Dr. Parikshit, for enlightening us with the detailed descriptions about how to go about for CRE and what are the steps to probably keep it under control and for appropriate use of antibiotics. And as you rightly said, it's a more of a team approach where intensivist in association with infectious disease specialist is so important along with microbiologists. So probably our way of looking into infectious diseases or infections in ICU probably has to be more broadened than just intensivist looking at those cultures. I would like to probably ask you to a few questions only, just sum up on this, and then we can end the session. So take home message first, and then we can end the session.
Yes, sir. So, important take home messages would be that when we are looking, our approach to Enterobacteriaceae should be different than Pseudomonas and Acinetobacter. So, something like Ceftazidime avibactam plus Astronam can be a good combination for E. coli Klebsiella, but it is a poor combination for Acinetobacter, and it may or may not work for Pseudomonas. So that has to be one thing. We have to try and develop infrastructure, for enzyme testing and so on. Remember that colistin MICs can be underestimated. So if your lab tells you a colistin MIC, it may actually be a little underestimated by Vitek systems. So we have to always take it with a pinch of salt. Remember, for E. coli Klebsiella, evidence for using combination therapy is more. So polymyxin plus something, combination therapy is more. For Pseudomonas, the evidence is decent, whereas for Acinetobacter, it's not that robust. And very importantly, when we are thinking of combination therapy, the answer should not always be polymyxin plus meropenem. We have to take into account the MICs, where we want these antibiotics to act before we really decide combination therapy. And last but not the least, as you very rightly mentioned, it's a team approach. So the ID physician, microbiologist, intensivist, they have to be all involved. Other teams for source control. So for example, if I'm treating a neurosurgical meningitis, unless the neurosurgeon helps me, let's say this is a shunt infection, unless the neurosurgeon helps me with source control, or if I have an abdominal abscess, unless the surgeon helps me with source control, all these things can fail. So as you rightly mentioned, it is a complete team approach.
Thank you very much. Thank you, Parikshit, and thank you, Pfizer, also for this very important topic. Thank you.
Thank you, sir.